Hi, everyone. My name is Joanna Tenkate, and I work at Global Heart Hub as their Patient Community Engagement and Development Lead. And I'm so excited to be here today for this webinar. As a quick background for anyone who may not know, Global Heart Hub is an alliance of heart patient organizations and advocates aiming to create a unified global voice for those living with or affected by heart disease. Now, you have joined us here today for Global Heart Hub's Empower webinar series, where we partner with patient organizations around the world to respond to the questions and needs of patients. And today, Global Heart Hub is delighted and so grateful to be partnering with the Diabetes Initiative Indonesia in support of our shared commitment to reaching and empowering the global patient community and creating a collective voice. And again, I want to welcome everyone to today's session where we will be talking about heart failure and its connected conditions. Now, we know that heart failure is rarely an isolated condition. It's often linked to other health conditions such as diabetes and kidney disease. And today, we hope to provide some essential insights into the connections between these conditions, why early detection matters, and how patients can take proactive steps in managing their health. Now, just as a bit of housekeeping before we get started, automated translated captions are available in over 35 languages in the caption button. I also want to note that this webinar is being recorded and will be made available online after the event. Now, with that, I'm excited to introduce our speakers very briefly who are with us today. Our first speaker will be Dr. Joe Gallagher, a clinical professor at University College Dublin, who's going to be talking about the science behind heart failure. After Dr. Gallagher, we will hear from Dr. Roy Sibarani, an endocrinology and metabolic disease consultant, who will explain how metabolic conditions influence heart failure risk. And then I'm very excited to have with us, for the patient perspective, two amazing advocates, Anita Sabidi from the Diabetes Initiative Indonesia, and Aistė Staraite, the development executive with Global Heart Hub, and the president of the Lithuanian Heart Failure Association. And they're going to be talking about the importance of understanding these connections and tips for early detection and management. Now, that's enough from me, and to get us started, I'll be handing it over now to Dr. Gallagher for his presentation.
Thanks so much, Joanna, and thanks everyone for joining this morning. It's wonderful to see in the chat for all over the world where people are joining from, and I'm really looking forward to discussing this very important topic with you all. So hopefully you can see the slides okay now, Joanna? Yeah, okay. So I'm going to talk about heart failure, and I've called it the 3 Ps, which is predict, prevent, and protect, and hopefully you'll see why I've chosen this by the end of the talk. I suppose heart failure is a very frightening term, and it's commonly thought by many people that heart failure means the heart has stopped or it's a heart attack. And really, it's neither of those things. It's really where there's a reduced ability of the heart to pump blood around the body or fill with blood. And it's classified into different types depending on how well that heart pump is functioning. And when I first started looking at this, I always found it difficult to understand. I could understand the pumping bit fine, but I couldn't really get why did the filling not make it an issue. So I use this analogy of a bicycle pump. If the pump is pumping, it works well. But equally, if you can't draw air back into the pump, it's not going to work very effectively. And it's the same with the heart. It won't work very well if it can't fill, if it's stiff. You will see, if you look at heart failure, a lot of talk about ejection fraction. And this is essentially the amount of blood or percentage of the blood in the heart chamber pumped out with each beat. Like any pump, the heart is not fully efficient. The normal range is 50 to 70% of the blood is pumped out with each beat. And if you have that problem with pumping blood, it's called reduced ejection fraction. You're not pumping it as well. But you can also have a problem where it's pumping fine, but it's not relaxing enough and it's stiff, and therefore it's called preserved ejection fraction. And just here on the right is an echocardiogram or ultrasound of the heart. And you can see here at the top of the picture is the ventricle or the chamber that pumps the blood, and it's barely moving. So this is this reduced ejection fraction heart failure that they talk about. So where is heart failure? It's a very common condition across the world. And you can see here, this map shows where it is most common, with the darker reds being where it is more common. I always have a caution about this because it often depends on what data is available also. But you can see it's a condition across the world and affects many people. On average, they say that 3 out of 100 people will have heart failure. But it's important to recognize that in actual fact, in younger people, it's much less common, maybe less than 1 in 100. Where if you're over 6 years of age, maybe 11 per 100 have it. And that makes sense. Like any pump, the longer you use it, the more likely it is to have problems. And as Joanna mentioned at the start, I think it's important to recognize it's not a condition on its own. Heart failure is generally caused by something else and it's commonly the end stage of some other condition. And as we'll talk about today, often managing these conditions can prevent the development of heart failure or indeed enhance its management. And this is just a slide from a chronic disease management program here in Ireland that was published last month. It looks at these variety of conditions that were in the program. And as you can see here at the bottom, heart failure was the condition least likely to occur on its own. Only 13% of patients with heart failure didn't have one of these other heart conditions, diabetes or lung conditions. So it's a big issue that not only does heart failure have a lot of side effects and symptoms itself, but also the other conditions that come with it add to that burden. And heart failure is particularly onerous to manage, and many of you will know this for both family and carers and the person themselves. This treatment burden is huge, from the medications to the appointments to the different treatments that are available, and something we need to be aware of as we develop these programs. So as I mentioned, heart failure is often caused by other conditions, and there's a wide variety of them that are associated. Joanna mentioned some of them, like diabetes, coronary artery disease, high blood pressure. Some people may have genetic heart problems where it can run in families. For some people who receive certain types of chemotherapy or radiation therapy to the chest area, that can make heart failure more common. More recently, we've recognized that conditions that can occur during pregnancy are a signal that women can develop heart failure later in life, and these are conditions with high blood pressure during pregnancy, such as preeclampsia. And then there are other factors such as excessive alcohol intake that can lead to heart failure also. And these are just some of them. There's a wide variety. But today we're going to focus on three main ones, which are very common, both common in terms of how often they occur, but also commonly occur together. And that's diabetes, kidney disease, and high blood pressure. And the three of them work together to affect the heart in similar ways and therefore have an additive effect. So for instance, diabetes, the high sugar can damage blood vessels, lead to some blockages, which decreases blood supply to the heart muscle. And it can also cause scarring or fibrosis, which leads to stiffening of the heart and makes it more difficult for it to pump. Kidney disease can lead to fluid overload, and the hormones that are released to sort of try and help deal with that can also lead to that scarring and fibrosis and make the heart stiff. And then hypertension and high blood pressure causes the heart to work harder, ultimately leading to thickening of the muscle and over time causing it to fail. Like any pump, if you drive it at high speed all the time, it's not going to keep working at that. So these conditions commonly occur together and can work together to cause heart problems. But we can manage these very well now. There's a lot of new treatments for these that can prevent heart failure. And even if you do have heart failure, it can help manage it. So what are the symptoms of heart failure? Symptoms we commonly hear about are things like shortness of breath, feeling much more fatigued, swollen ankles, unexpected weight gain. But the problem is that often overlaps with many other conditions. It's very difficult to diagnose heart failure in many ways because it's a very slow onset syndrome often, where these symptoms gradually develop. And because of so many other conditions that people tend to have, they'll sometimes put it down to the medication or the other conditions. And that can lead to a delay in diagnosis. We see this across the world where there's people with heart failure often take quite a bit of time to get a diagnosis. So I often say, if you're in doubt, check it out. The good news is that of people who have these symptoms, when they go to a heart failure clinic, 70% won't have heart failure. But if you do have heart failure, we now have fantastic treatments that can really improve your heart function and get it working better. These were just some quotes from some patients in our clinic here in Ireland, which I thought were useful, that just showed the difficulty they found in coming to sort of recognize were the symptoms due to a new condition or due to some of the conditions they already had, and also the reluctance often to come to the GP with another problem where they might have to deal with more medication and more treatments, coming back to that treatment burden and a worry about what might be revealed. So it's a very difficult condition to try and get on top of. But as I said, we have fantastic treatments now to manage it. So the three P's are that we can predict those at greatest risk of developing heart failure. Then we can focus on preventing the development of heart failure. And finally, for people who have heart failure, we can protect their heart so that they don't have worsening conditions. Why is prediction, early detection important? Because heart failure often progresses silently. It's not something that appears all of a sudden. Often it's many years of constant damage, and bit by bit it develops gradually. And if we can intervene early, we can prevent that progressing. So think about what risk factors do you have? These are the same as for many other family conditions. Some we can change, like our age and family history. Others we can manage better, like high blood pressure and diabetes. And then we can look at things such as smoking, alcohol, and low physical activity. So which of those do we have? Do you know your numbers? I think the more we can get involved in our care. Do you know what your blood pressure was in the last visit, your HbA1c, your weight, your cholesterol, your kidney function? I think as a healthcare provider, we've been very poor at sharing that information with people, but you should have every right to demand it if we forget to give it to you, because this is important. If you don't know what the numbers are, how can you help manage them? So engaging us in care. Well, one of the important things about heart failure is it's sort of been ignored by the medical community for a long time. This was an interesting study published in the British Medical Journal. It looked at risk models to predict heart disease in the population. So used models that were used to help healthcare providers identify those at highest risk. They found 363 different risk models. The doctors loved doing these risk models, but out of that 363, only one looked at heart failure. So all the others were looking at things like heart attacks and strokes. But as we said, heart failure is a really common problem with a lot of burden on family and carers and the person themselves. So we need to do better at predicting it and identifying it. And one of the ways we can do that is through a blood test called natriuretic peptides. So natriuretic peptides are hormones released by the ventricles in the heart in response to stress. And they're a good hormone. They protect the heart against damage. And in the laboratory, depending on where you are in the world, there's two main types measured. One is called BNP and one is called NT-proBNP. Which one is used doesn't really matter. It just depends on what one is locally. But the important thing about natriuretic peptides is they respond to all sorts of stress in the heart. So whether it's strain or scarring or reduced blood supply or fluid overload, the heart responds and says, I need to release this to protect the heart. So if your natriuretic peptide, your BNP or NT-proBNP is elevated, it's your heart saying, I'm under a little bit of stress and I need something to help get that better under control. And so the question is this better at predicting heart failure than the other conditions we talked about, such as smoking, blood pressure, cholesterol, diabetes? And this study looked at over 95,000 people. And what it found was that the higher NT-proBNP, the better it was at predicting your risk of heart failure, in addition to those other risk factors. So really using it helping us predict the risk of developing heart failure. But the next question is, can you use that to prevent it? Can you do better at preventing heart failure if you know that you're at higher risk? And the good news is that yes, you can. And this was a study we did here in Ireland, which looked at using that BNP and NT-proBNP in people who didn't have heart failure, but had other risk factors like diabetes or high blood pressure or stroke. And we measured this blood test in that population and then targeted care to that group who had a higher level than normal. It involved 39 family medicine and general practice along the east coast of Ireland, which you can see laid out here. And we had one hospital involved as well in Dublin. You might wonder, why was there no one here in the middle? And this is a little plug for Irish tourism. It's because that's a national park that we have that has lovely scenery. If ever you come to visit Ireland, you come see it. But there's no humans there. All we have is deer. So there's no point checking them for anything. So that's why there's nothing in the middle. But the interesting thing with this, not using any new treatments, but just targeting care better to this population, we reduce the risk of new onset heart failure by 40%. What was really interesting, that's what we set out to do, was to reduce the risk of heart failure. But as you'd expect, if you manage these risk factors better, you reduce the risk of all the new conditions. So there's a 46% reduction overall in the risk of things like atrial fibrillation, heart attack, stroke, and clots. So this sort of allowed us to intervene earlier and prevent that progression to heart failure. And this approach is now part of a number of North American guidelines. Question is, what about in the community? It's all great to do this in studies, but what about in the general community? And we looked at this in the community diabetes population in Ireland, and we used the same approach, used it to identify those most at risk. It was an interesting cohort because we were really well controlled. Those who had a high NT-proBNP, they actually had very good values of HbA1c and cholesterol and blood pressure. The only thing that stood out was that their NT-proBNP was elevated. But when we did echocardiography or cardiac ultrasound, we found almost a third of them had significant heart dysfunction, and this allowed us to intervene early before symptoms began. So, good news, we can prevent heart failure through good treatment and prevention. We can identify it early. But what about if you have heart failure already? How can we protect your heart? I mentioned that before. We didn't really have much focus on heart failure in medicine, but that's changed dramatically in the last couple of years. And now we have really good treatments, particularly for that heart failure reduced ejection fraction. They had talked about these 4 pillars or 4 drugs that everyone should use to get their heart function better. And although it adds to the treatment burden, the fantastic news is it has a fantastic improvement in terms of both survival and also avoiding hospitalization, in addition to what was already there. So previously we used these 2 medications, an ACE inhibitor and a beta blocker. But now with these four drugs, you are looking at significantly increased life expectancy and significantly reduced hospitalizations on top of what was already there. So good news, we can really manage these much better and not only avoid these events, but also improve quality of life. And we'll hear from that later. The other important plug I'm going to give here is influenza vaccine. We forget about this, but this is an interesting study from Denmark, which looked at people with heart failure who got influenza vaccine, and it reduced their risk of death by 18%. It's a fantastic intervention. What's interesting was the earlier you got the vaccine in your flu season, the better it was as well. You can see here, if you got it in September, you had less risk than if you got it in October, than if you got it in November, which is the flu season there. So it's about thinking about all the things that can impact on your heart, not just the medications and drugs, but also influenza puts that extra strain on it. So, in summary, predicting heart failure. Know your risk factors. They're the same as for many other conditions. Have a high index of suspicion. I know it's hard when you have a lot of things going on to think, God, I'm feeling a little bit worse. Should I go to the doctor again? And what if they find something? But the important thing is we can identify this earlier and treat it much better now. So that don't be worried. And know your numbers. Feel part of that care. And particularly now this blood test BNP or NT-proBNP, if it's available, it guides as to your risk of heart failure. Prevention uses the same common approach as many other disease, but also managing conditions like diabetes and high blood pressure to protect your heart. If you have heart failure, it's all of the above. Take your medication regularly. Remember your vaccines. And importantly, heart failure management is changing and improving dramatically. But I think most importantly, what I want to say is, it's like a Formula One race, but you're the driver, you're driving the engine. We're just a pit stop team helping you to do this, supporting you at every turn. Stay involved in your career, stay informed, and together we'll win the race. Thanks very much.
Thank you so much, Dr. Gallagher, for that presentation. I know I learned a lot. I think it was a great introduction to why understanding the connections between these conditions is so important and why proactive care and detection matters so much. So again, thank you so much for being here. Now that we've gotten a good understanding of the perspective from heart failure, I'm delighted to bring Dr. Cibarani up on screen so he can talk about the landscape from the perspective of metabolic conditions and their impact on heart failure. So Dr. Cibarani, we'd invite you now to give your presentation. Oh, sorry, doctor, you're
Yes,
muted.
I need to. Yeah. Okay. Thank you, Joanna. Good afternoon, Atandi. Thank you very much, firstly, for Global Heart Hub organization to having me here in this very important webinar and so interesting. Let me share my screen. I hope it works. Okay. Hi, everybody. Welcome to the webinar. I know that the topic of diabetes and heart failure sounds so seriously, but don't worry. We are here to learn together in a relaxing way, meaningful way, and also hopefully is a inspiration way. Because health is not just a doctor's responsibility. It is a communication effort. Now, let's get started. I am Roy Panusunan Sibarani. I am working in Bogor, Indonesia. And Indonesia is a country with a population of 285 million people and the number 4 in the world as the most populous country. Now, being a number 4 population country in the world, Indonesia gaining the position as the country with the 5th largest population of diabetes in the world. And the number has increased from the previous population. Likewise, for future population in 2050. This increases for sure is not only happens in Indonesia, but also throughout the world. As we see in this slide, how the number of people with diabetes is increasing and increasing and increasing in the all part of the world. And even in Africa region, this increasing reach 124%, 142% of the population of the increasing. So this is a very sad. And in South Asia, we only increasing not too much comparing to the 2050, but we are predicted to increase in 80% only. So in Europe, they are all very careful with this, and they think that in Europe in 2050 it's only increasing for 10%. So behind this, there is a one condition that accelerated death, namely cardiovascular disease. And diabetes pointed to 60% high risk of developing cardiovascular disease. And this incident will increase the state's cost of required to treat diabetes and its complications for sure. But what even sadder is approximately 3.4 million adults aged 20 to 79 years are estimated to have died because of diabetes or its complication in the year 2024. And 40% occurred in the most economically active age group. And this is so sad for us. In Indonesia, more than 131,000 people died because of the complication, diabetes, and cardiovascular disease. And this risk, and behind that, there is one condition that accelerated death, namely cardiovascular disease, as you know, and diabetes pointed to 60% higher risk of developed form of cardiovascular disease and even 84% of heart failure. So this diabetes condition is really equivalent with diabetes. So we should have to emphasize that when we see people with diabetes, it means that we see people with cardiovascular disease condition, and it's very equivalent. And so about the heart failure, the presence of heart failure in patients with diabetes is associated again with an increased risk of diabetes. This presence of heart failure in diabetes, will increase all the death, like Bertoni's report. But the evidence of the survival for diabetes patients were significantly lower in those who develop heart failure compared with those without. And this study have other evidence and more study proof to the evidence of this condition. Diabetes, and thank you for Dr. Gallagher that already make my talk is easier, because Dr. Gallagher also already explained how the diabetes can affect the heart failure and condition and the symptoms of the heart failure. But I'm going to talk about far beyond that. I'm going to talk about some condition that can be prevented. And diabetes can lead heart failure through both atherosclerotic mediated and atherosclerotic independent mechanism. It means that there are two ways of people with diabetes to get heart failure. They can just affected by the problem in their vascular, and also they can get problems, heart failure, to direct inflammation of the microvascular effect on the myocard, and those related to diabetes. But we all know that the best medicines is prevention. We know that, as Benjamin Franklin quotes, an ounce of prevention is worth as a pound of cure. So that is the beauty of making a prevention, beauty of knowing the risk of the disease. And we need to take part of this and try to find the disease and the risk as soon as we can, as possible. And we see recently some expert put guidelines for those for this attempt of prevention, and it is called CMBCD, cardiometabolic based chronic disease. and they have stages and its anticipation. We have stages one. Stages one is talking about the primary driver, metabolic driver two, metabolic driver like adiposity and chronic disease, like adiposity function, adiposity distribution, and metabolic driver two, talking about insulin resistance. We're going to talk a little bit with this insulin resistance in the final part of this presentation. And also the stage one is talking about hypertension and dyslipidemia. We see that there is stage one, stage two, stage three, and stage four. And we have also this primary driver like genetic. You know, genetic is still unexplained. We still have to find more genomic proof. But actually, a familiar inheritance is more dependent on modifiable risk. We have environment. Some variables are associated with cardiovascular disease as lower socioeconomic strata, decreased access to quality health, like here in Indonesia, and low education and literacy level, and also both urban and rural habitats. We also have behavior with respect to prevalence rate of specific modifiable cardiovascular disease by tobacco smoking, alcohol drinking, absence of leisure time, lack of physical activity, which is so common here in Jakarta, Indonesia, and low fruit or vegetable consumption included and also included. And this is the very first of this stage. And we have stage 2, stage 3, stage 4. But I would like to bring you to the other side of vision. I would like you to see this in the way that International Civil Aviation Organization that develops safety management system. That's a weird way, but I know in the core is every soul is worth it. When you are going by airplane, we know all attempts are going to make we are safe to go to our destination. And safety is freedom from the occurrence of risk of injury, danger, or loss. And safety management system provide a systematically way to identify and control risk and assurance that risk control remains effective. I repeat, control risk and assurance that risk of controls remains effective. Now we see this part of the safety management system. What is the beautiful of it that in SMS, all potential risk and hazard described chronologically and always remembered, because all things will be in a continuous circle and will be discussed until people always remember what will be happen to the people at risk. Now we see that hazard identification in definition, identifying factors that have the potential to become hazard for people with diabetes or individual at risk of diabetes, which could lead to disease onset or complication. Example hazard is sedentary lifestyle, diet high in sugar and saturated fat, family history of diabetes, chronic stress, history of gestational diabetes. And the tool that we can use is initial medical checkup, of course, very easy for hazard identification, and also diabetes risk score, like we know that the Finnish risk, food and activity diary, and also psychosocial assessment. Then we go to the other side of this SMS, which is risk identification. Risk identification, identifying the risk that may arise from the detected hazard, both regarding the onset of diabetes and potential complication. For example, the risk: chronic hyperglycemia, hypoglycemia, diabetic retinopathy, the kidney disorder, coronary heart disease. And the tool is laboratory assessment like HbA1c, lipid profile, EGFR, and so forth. And also eye screening and ECG treadmill test. Then we go to the initial risk assessment. Initial risk assessment can come to the part of the mitigation of the condition, like we see here, that conducting an initial assessment of the identified risk for determine the level, severity, and likelihood of occurrence. So from this, we know that we put the patient or we put the people with diabetes, the likelihood and severity and the risk value like frequent, occasionally or remote, and severity like catastrophic, major or minor, and also the risk value. The outcome, patients are categorized into risk stratification as low risk, as moderate risk, and high risk, and very high risk. Then we come to the mitigation of all this, and then we go to the risk monitoring policy. What should we do after having all those problems? And we see that developing a risk monitoring policy is developing a policy for periodic monitoring of risk to ensure they remain controlled and prevent escalation. Example of this monitoring policies is HbA1c every 3 months for high-risk patient, serum creatinine every 6 months, it's very important, and urine albumin creatinine ratio every 6 months, retinopathy screen once a year, and food examination every 3 months, and monitoring lifestyle and medication adherence. And this is something that is very important. And monitoring mobile methods can be mobile, can be with diabetes registry and other tools to do. Then after risk monitoring policy, you know that albumin urine creatinine ratio is such an important thing to remember because albuminuria is a prevalence in patient with heart failure and confers a strong, consistent, and independent association with risk. The cause of albuminuria in patients with heart failure are incompletely understood, as are the mechanism linking to disease progression and adverse outcome. But the intervention that reduce albuminuria may potentially lower the risk of incidence of heart failure. It's the very beauty of it, or prevent progression of existing heart failure. So albumin urine creatinine ratio is a must to do to prevent heart failure to do so. Like what we did in Indonesia in our Buitenzorg study, we examined 153 patients with diabetes, and among those patients with a diabetes duration of more than 8 years, 36% had heart failure preserved ejection fraction. And among patients with a diabetes duration less than 8 years but had albuminuria, 43% had heart failure preserved ejection fraction. And patient with the diabetes duration less than 8 years but with hypertension, probability to have heart failure preserved ejection fraction is 10%. This is the result of our study in Bogor, the place where I'm working now. Now we go back to the risk events and correlation matrix. Creating a matrix to link hazard with resulting event outcomes, so causal relation can be analyzed. And we see it can be, the hazard can be, for example, hazard can be sedentary lifestyle, the event is weight gain, and severity is medium, and also what we did is, kind of exercise program. Now, we go to data analysis, and we see that data analysis will be remembered and also being discussed with everybody, so we know that we are going to do everything to prevent this complication. How do we do this? I believe that we need some kind of facility or institution to make it happen. Like I said, this is the the cardiometabolic clinic, which focus on primary and secondary prevention of atherosclerosis, cardiovascular disease, and diabetes rather than advanced treatment offered in typical cardiology and endocrinology clinic. You can see the team that is working for the cardiometabolic clinic. It can be the doctors, the nurse, and also the nutrition, the pharmacist. This is the team that can, discuss the problem of the patient. And as the International Aviation Organization said, one soul is worth, then we are going to discuss it over and over. But how to do it is not that easy because we need so many people to the stakeholder to help the cardiometabolic clinic for preventing the heart failure and cardiovascular disease for people with diabetes. We need to work with the government. We need to work with the patient itself. The patient need to be understood why they need to go to the hospital every 1 month or every 2 weeks or every 3 months and follow the regulation or the guidelines that we are doing to them. This is quite, challenging for the patient. And also we need insurance company to understand what should we do in the preventing of cardiovascular metabolic disease in diabetic people. And we need to have a cardiometabolic clinic is the one part of the hospital to have the promotion of preventing program for heart disease, especially for diabetes people. Okay, let's get a little bit about insulin resistance. I know that insulin resistance is commonly seen in diabetes, obesity, and metabolic syndrome and remain unresolved and may be differs. But I have to say that the insulin resistance, I believe, happen because we are getting energy is much, much more than we lose the energy. So we gain weight and then the insulin resistance will happen, whatever it is. And if we want to reverse the insulin resistance, so we do the reverse thing. So we less of energy intake and more activity to do like we do here in Indonesia. We have a program now named Move Dance, which we perform this and introduce this to people all around us to do exercise. And it could be done in the office and in the hospital or in the government employee. Then this make them more active, more energy to spend than energy to eat. And now for the take-home notes. Diabetes cases are increasing every year throughout the world. CVD might be a major complication of type 2 diabetes and result in a significant morbidity and mortality. Heart failure is considered a global pandemic. Efforts to treat modified risk factor for heart failure is needed. And collaboration of stakeholders is essential in diabetes management and cardiovascular prevention. And insulin resistance is an important clinical issue, and treatment strategies that improve insulin resistance could reduce the risk of the vascular disease. And thank you very much. I give back to you, Joanna. Thank you.
Thank you so much, Dr. Subarani, for that presentation. That was so helpful for me to understand what this looks like on the perspective of cardiovascular disease and diabetes and other metabolic conditions. So I really appreciate you being with us today. Now, I'm very excited to spend the rest of our session together with our two wonderful patient advocates, Anita and Aistė. If I might ask Anita, if you could please introduce yourself, share a little bit about why you wanted to speak on the webinar today.
Everyone, my name is Anita Sabidi from Jakarta, Indonesia. I live with type 1 diabetes for the last 28 years and later diagnosed with cardiomyopathy and chronic kidney disease. And I'm really passionate bringing awareness towards the connection between diabetes and other health conditions since I personally experienced it. And that's why I'm really grateful to be here today with Global Heart Hub.
Thank you so much, Anita, and we'll get more into these topics when we get to our discussion questions. But Aistė, I'd love if you might be able to introduce yourself as well.
Thank you very much, Joanna. Hello, everyone. My name is Aistė Staraite. As Joanna mentioned in the beginning, I'm a president of Lithuanian Heart Failure Association, but I as well take a role at Global Heart Hub as development executive working in the heart failure space. I'm a survivor as well, so I can really speak in terms of lived experience and challenges. And I'm very excited to be here today because heart failure and the awareness about the disease is one of the key goals for me to increase globally and to support patients who are living and, of course, to educate the society to focus on heart health.
Absolutely. Thank you so much, Aistė. And actually, Aistė, if I could start with you, just kind of on a ground level, we've heard a lot today that heart failure is so closely connected with all of these different conditions. I was really struck by the slide Dr. Gallagher shared about showing how there was such a small portion of people who only had heart failure. So many of them, the vast majority of them, did have these other conditions. So I want to start just by asking you, why do you think it's so important that we have these conversations about this connection and what it means for patients who are living with them?
Absolutely, Jana. I was impressed as well about the presentations, both in terms of heart failure, even though I know heart failure topic pretty well from different perspectives. But I think hearing as well about diabetes is really interesting and really informative, because I think in a sense we do lack information, of providing information to the community. But I think your question was like, why is it important, right? I think it's really important because it really can direct patient's journey. So it is really important if the patient is engaged, for example, and they actively engage in, for example, monitoring their health, adapting the new lifestyles, for example, there is a higher chance that they will have a better quality of life and better outcomes. So it is really all about being proactive yourself as someone who lives with one, two, or multiple conditions, and actually being the owner of your own health. And I would really like to highlight that, being the owner of your own health. And to the point where that's as well what I did myself, is like asking the question myself, what I can do today for myself to have a better tomorrow. And then you are more motivated to take certain actions. Can I learn more? Can I actually, as Dr. Barani said, move more, go for a longer walk today, because I know that will help me tomorrow.
Yeah, that really resonates with me. In both of these presentations, we're seeing that there are so many actions people can take to be proactive in their health and take control of their health. It's just about knowing what they are and how to do them. Actually, that brings me to a question for you, Anita. You have lived experience both of heart disease and cardiomyopathy and of diabetes, and you work so closely with the diabetes community in Indonesia. Can you tell me, in your perspective, what is the level of awareness, say, among the diabetes community of their risks of heart failure? Is this something people know about, or is there more work to be done in raising awareness?
We need more work to be done, of course. We need to recognize the connection between those conditions, diabetes and heart failure. Why? Because as a person with diabetes, we often too focus on managing our blood sugar. And when we develop complications, the stigma is there. So we often hide our condition because we fear of the stigma of people telling us that we fail to manage our diabetes. So we develop complications. But diabetes is very complex. And when Dr. Gallagher presented the presentation, I could connect all the dots because I have diabetes. I experienced preeclampsia, and then I developed cardiomyopathy and cardiac disease. I mean, it sounds. I mean, it sounds logical to me why I develop complications because it's really that complex. But this understanding is not well aware in our community. Why? Because discussing complications is not an easy topic. So the question is, how can we provide those understanding to our community? And if we go through to the detail, there'll be a lot of layers of challenges from screening because is it okay? Or you just
No, absolutely. Everything you're saying is so accurate. I actually think maybe we could start with the idea of, like, say, these layers and how we find them all. Do you find that there is good overlap within, say, the healthcare system, or are you working with a doctor and they're just looking at your diabetes and then you have to go somewhere else to talk about your heart failure? Maybe you could comment a little bit about the healthcare system in that way.
Yes. When Dr. Gallagher mentioned about know your numbers, as a person with diabetes, I thought that checking our blood pressure is enough for us to prevent heart failure. But is it enough? Apparently, it's not because since I developed cardiomyopathy, it turns out after a discussion with my cardiologist, so I need to do MRI or CT scan to know further about my heart condition, which is not available yet in the system. It's available, but since our main condition is diabetes, which means that you need to be referred to another specialist. So that will be another layer of challenges. Why? Because you need to mobilize yourself, seeking another specialist or even to another hospital to have a further heart consultation. And keep in mind, Indonesia is a low middle income country, which means that if you need another specialist, it also means that you need to travel to another hospital, a bigger hospital in another island, bigger island. So it's not easy. So I still remember one of my discussion with the government is that they asked me back on since we have 19.5 million people with diabetes, on what is the most affordable, feasible heart screening for people with diabetes. Well, we have 19.5 million people with diabetes in the country. That's homework.
You know, that's really interesting. Sort of you're touching on this idea of somebody who's living with, say, diabetes or living with heart failure or any of these metabolic conditions who are entering the health system, and then they just kind of get bounced around if they're getting access to what they need at all. Aistė, I'd be curious to know your perspective on this, you know, the access within the healthcare system.
Thank you very much, Jana. Actually, while Anita was talking, I really wanted to bring in the work of Global Heart Hub, what we did as a community. So last year, Global Heart Hub had a Unite Summit on connected conditions specifically. And there's a report launched focusing on the key community challenges. And we had, in the event, we had 165 attendants, and we surveyed them during the conference, asking different questions, including the challenges that patients face. And exactly what Anita mentioned, I can mention there's a key top priorities, I would say, and I can go very quickly through that. So one of the first ones is the potentially that people experience uncoordinated care. So, and that failed to address actually interconnected conditions. The second is early detection and prevention. It's not, it is inadequate. You know, the patients are not being diagnosed and they've not received the optimal interventions. The third one is overall structural barriers in care coordination. So lack of patient navigators that we see in different countries are working really well. Or for example, shared records and integrated teams. Yeah. And that of course affects the treatment. The fourth one is talking about the innovation and digital health adaptation. We have a lot of great tools that we could potentially use, but we are still have limited access to those and limited access to, for example, AI-driven diagnostics, telehealth, advanced therapies, and etc. The fifth one is very important, talking about the equity gaps. And, you know, how do we look at across the gender, ethnicity, geographic, and socioeconomic backgrounds? And the sixth one as well, which is extremely important as well, is mental health. So it needs a bigger focus on the mental health, on the greater recognition about that integration as well in cardiovascular care and as well with the multimorbidity care.
Thank you so much for that. Such a comprehensive answer, Aistė. And there's actually something you mentioned I'd like to sort of touch on as well, which is this side of mental health, because something we're talking a lot about today is this idea that patients can take proactive steps and take control of their own health. But with that, we have to recognize that there is an emotional and logistical burden to that, especially when you're engaging with a system that's not set up in a holistic way. And you do have to sort of juggle all of these different challenges. So maybe Anita, I could return to you for your opinion on how we might be able to recognize some of the emotional challenges that come with this and why having comprehensive care might be able to improve some of those.
Yeah, I think community support means a lot in terms of mental health, because as a person with diabetes and then you develop complications, it's really difficult to have conversation with people who are not in your community because they will stigmatize you. But when you're going to a right community and they know that the challenges as a person with diabetes complications, they will support you and provided you encouragement to move forward. It's interesting because most people with diabetes with complications, they fear knowing their complications. They prefer not knowing about it because they fear of the stigma that's in their society. And I think that's where the community are there, because we're providing support. I mean, you still can have an improvement in your health, although with complications, even with heart failures, for example.
You brought up something that's so important, which is that there is sometimes a mental barrier to doing
Yep.
some of these things like early detection and early testing, going to get your numbers, because
Yep.
there is an emotional toll to that, constantly putting yourself in the hands of the healthcare system and having to confront things that can be very frightening. And you really brought up a great point, which is the importance of having community support so people feel like they're not alone and that they have support in going through something like that. I see if I could get your opinion sort of on that idea of community support, but also the role patient organizations might play in providing some of that support and also some of the information that people are looking for when it comes to these complications.
Absolutely. The community support is extremely important, and that relies into like peer-to-peer support. And we know that patient organizations, one of the key goals of the patient organizations that we see globally, they actually work in those areas. So some of them, they focus more on the awareness, some of them, they focus more on the peer-to-peer support. And what I would like to say, for example, in our community at Global Heart Hub, and as well as a leader of the patient organization, talking to the patients and working along together with them in Lithuania, I can say that each patient organization has a role in patient education specifically. And for example, in Global Heart Hub community, like through the awareness campaigns last year, in 2024, we have achieved 450 million impressions. And this is a very powerful impact when all the patient organizations are coming together to focus on the cardiovascular with intention to educate, empower, and improve disease awareness overall. But it's not only about the awareness campaign. Sometimes it's more about having the community get together and as well providing, for example, educational sessions on different topics. And those topics come in on the demand what the community needs. So what we see in the past couple of years, there's a very big focus in terms of heart failure and connected conditions, or diabetes and connected conditions, and kidney disease connected conditions, because this is extremely common and there is a lack of knowledge and lack of understanding how it works from the patient community, from the society as well. And obviously, we are here as a patient organization. We have a great opportunity as well to educate, because while we create the educational content and materials, we always collaborate with clinical specialists. So the information is trustworthy and we can provide that to the communities.
Thank you, Aistė. And something else that kind of came to mind as you were speaking is your excellent point on the fact that these conditions are so connected. So if these communities and these organizations across these connected conditions can work together, we can reach even more people, and we can remind people that they're not alone and that this community is so much larger than they might even realize. Now, we're going to be finishing with just a couple of slides from you, Aistė, but before we get to that, I was thinking maybe for a final closing thought, I would ask both of you to share with me your opinion on why early detection is so important and what that means for a patient and the impact it can have on their life. Maybe Anita, I'd start with you.
Okay. Early detection is important. Why? Because early intervention and early treatment means delaying the progression of the complications.
Absolutely. Thank you so much, Anita. And Aistė.
So I have a saying, and it's very, it's not unique, but it's true. And I'm speaking actually from lived experience. And I always say, so earlier diagnosis, better care, leads to better care and to the more options of the treatment. It's slower progression of the conditions, but as well leads to the better quality of life, to the better outcomes and survival rates. And I really like the quote. Because we have a heart failure awareness campaign on an annual basis, I had interviewed a couple of different specialists, and one of the specialists from Poland, a cardiologist, Professor Agnieszka Olsachenka, actually said a very, very good quote, which I would like to mention to you as well. And I quote, she was saying, know your numbers. By lowering blood pressure by 5 milliliters lowers the risk of heart failure by 13% in 10-year perspective. Lowering of cholesterol by 1 millimole lowers the risk of coronary artery disease by 22%. So it is very important to start from the simple test and repeat those tests. So we know the importance of screening, the importance of regular checks, and we have to take an ownership as a human beings.
Thank you so much. I see that's actually a great quote, and it's about how small actions and doing things early and often can make such an enormous impact to somebody's quality of life. So I want to thank both of you being here for sharing these insights with us. It's so valuable to hear directly from people with lived experience. Now, with the last few minutes, I'm going to keep Aistė here on screen to share just a few slides with us, which can come up now. As you may know, we are in the midst of Heart Failure Awareness Campaign, and this campaign is all about the heart failure and its connected conditions. So Aistė, I'd invite you to share a little more about this campaign.
Absolutely. On annual basis, we actually commemorate heart failure awareness. And with every month, we want to focus on why heart failure is important. And since last year, we have been talking about heart failure and connected conditions. So last year is more about, please know that this happens. Please know that if you have heart failure, you need to look at different connected conditions that can impact and as well, worsen your heart failure. This year, we want to go a little bit deeper. And our campaign name is Heart Failure, the Whole Story. We do not want to look at heart failure as on its own and to be treated on its own. We need to look at it as a whole story, the whole picture. What comes along together with heart failure is another conditions, is it a mental health? And we want to look as understanding and treating the whole person. We don't treat one condition to support and improve the condition for that person, but we want to look at the bigger picture. We can move to the next slide. So what does it mean? So what is the major issue? So there are two key issues that we see, and that's why we approach this campaign. So first of all is the lack of education and awareness about the interconnectedness of heart failure and its connected conditions, such as, for example, kidney disease, diabetes, and you see the list on the slide below. There's overall low general public awareness and low patient awareness of these related conditions, and it's significantly impacting on early detection, on its diagnosis and management. And as well, the second issue is there is a poor integrated care and management of these connected conditions within the healthcare systems. So we want to encourage everyone to work together so we can provide that holistic approach to the patients. Next slide. So this year, actually, we have a little bit different approach to the campaign. Normally, we will have the campaign for the whole month, and we will target it to the public and the patients. This year, we actually starting in May, and we will continue communicating our messages until the end of the year. But we have two different audience groups as well. So first of all is patients and the publics. We want to activate and encourage patients and carers proactively engage with their healthcare providers as to so optimize the care pathways and improve the outcomes. And as well, the message to healthcare professionals is not only to raise the awareness and highlight, of course, to the general public and healthcare professionals about the importance of knowing the disease and relationship between those connected conditions and the challenges. Next slide, please. And this is how our campaign looks like. If you would like to find out more, there's a QR code so you can scan it and it will lead you to the more information. If you see this slides and those posts on social channels, please do reshare because that can save life. Thank you very much, Anna.
Thank you, Aistė. I know you only had a couple of minutes to share that, but it was really excellent to see more about this campaign. And I know there's going to be a lot coming in the coming weeks and the coming months. And I think it'll be an excellent source of awareness and education for patients all around the world. So thank you for sharing that with us. Now, we've only got a couple minutes left, so I'm going to wrap us up. I want to thank all of our panelists for joining us today and sharing their expertise and their experience with us. I got a lot out of this discussion. I learned a lot today that I didn't know before, and I hope our audience feels the same. I appreciate all of you being here. I'm also grateful as well to have been able to partner with Anita from the Diabetes Initiative Indonesia. She's such an excellent collaborator with us, and she brings a wealth of experience and expertise. And so thank you so much again for your time and your partnership in this webinar. Thank you as well to everyone in our audience. I hope this was valuable for you, and I appreciate you spending this hour with us. Now, when we exit, you should see a survey for this webinar come up. I hope you'll take the time to fill it out so we can always continue to improve. And I will send out the recording of today's session to all attendees. Now, anyone else is interested in learning more about our work, please feel free to reach out to me. Otherwise, just thank you again, and I hope to see you at our next webinar. Goodbye, everyone.